think this talk might run a bit over. Got a nice straight road heading towards the rainbow. I don't have those answers for you. There is not a simple answer to a lot of these questions. So we're going to take a bit of a left turn through some personal thoughts about how ICU tries to modify risk after the fact, because that's generally when we get involved. The difference between perceived and likely problems for our patients, what they think might happen, what will happen. And I'm going to take you through a little bit of the literature around critical illness and outcomes, which is becoming increasingly important in my field, and then bring it hopefully together in discussion about high-risk scenarios and some ways we can talk to people about these things. And sometimes it's just worthwhile to state the obvious. Very quickly, you can always have an argument about the best way to do VTE prophylaxis, and I've got a whole lot of studies here. What I can't do, and Jenny and I are on the same research ethics committee, is put up a trial with placebo. And a lot of little things in the post-operative care of the patient put in place, done effectively and timely, will alter outcome, but it's a very, very hard thing to measure. And the ICU perspective is that this acute prevention is very important, and it's system processes, many small measures, what we call housekeeping, that improves outcome. It's not very dramatic, it's not very sexy, but it works. And the exact way to do this is unfortunately a shifting target. And this is, I'll just take you through quickly, the VISION trial, 15,000 patients. This trial has been a nightmare to all of those who do post-operative care. This is your mortality related to your post-operative troponin. And the first risk is a high normal range troponin. And you can see that with an elevated troponin, you're more likely to die within 30 days of your operation. It's the 30-day mortality that we measure. Trouble is, you don't die that day, you don't die the next day, you die sometime in the next 30 days. So how do we prevent that? Well, that's easy. We give people aspirin. So a number of you here, I know, were involved in this trial. 10,000 patients undergoing elective non-cardiac surgery who are moderate risk, looking at aspirin, clonidine, placebo. Just looking at the aspirin side of the trial and the Kaplan-Meier curves, you can see they're pretty much identical. Aspirin is very good at preventing cardiac events, but it significantly increases your risk of bleeding. The people who had aspirin-related bleeds were very likely to have a myocardial infarct. So sometimes the shifting target is actually quite hard to find. And on the graph there, you can see falling mortality for a range of procedures. It's US data. I can find a graph for just about any procedure in the world showing risk-related mortality falls. We're getting better and better at doing things, but we do have tools that concentrate on mortality. And as we've been talking about, mortality is a very rare and it's a decreasing event. And population prediction is not individual outcome. With apologies to the neurosurgeons, if I collapse now and have a subarachnoid, go off and have my CT scan and someone rates me as having a 30% chance of death, that doesn't tell me whether I'm dead, whether I'm hemiplegic and don't recognise my family, or whether I've made a good recovery. So individual outcomes are very different to population outcomes. The other thing is death might not be the only thing we need to be thinking about. Like looking at medicine from the outside, this is a web commentator called Randall Munro, who apparently is very clever, used to be a physicist for NASA. His partner had breast cancer, and this was his perception of cancer. This is, he then did this. This is a mathematically correct model of stage 1 through 4 as you go across survival of cancer patients. People's perception of disease processes and a yes-no answer is very different to the reality. And if you ask people about high-risk surgery, high-risk procedures, such as transcutaneous aortic valve, they think you have the procedure and you get better, or you're dead. Generally, you die under anaesthetic. Now, we know that's not what happens. Anaesthetic deaths are vanishingly rare. Or if you ask for someone for a more nuanced thing, maybe you get a complication, you go to intensive care, you die, or you get better. The reality looks something more like this. You have your procedure, you may well get a complication, hopefully you'll get a recovery, some people will die, but many people will recover, but with a remaining level of disability. Is that important? This is a landmark paper that informed a lot of subsequent research, and this was very important when people were considering thrombolysis for strokes. And this is people rating outcomes. And I've highlighted that death has a risk of around 10, and major motor impairment, major cognitive impairment, is rated as worse than death. Not all disability is acceptable. And we're going to come back to this case. This man's very unfortunate. He's a nursing home resident, he has a colon mass, and he lives in the USA, because that's where the stats came from. What I'm going to do now is look at some of the intensive care literature that's started to change the way we think about intensive care recovery. ARDS sometimes occurs after surgery, but not always. This is Margaret Herridge from Canada's work. She looked at 117 survivors. These were young, 45 average age. I think that's very young these days. ICU length of stay of a month. Hospital stay more than a month. 50% with the tracheostomy. These were very sick people when they were in the ICU, but 83% of them had no or one pre-existing condition. 83% of them had a job. They were working full-time. And she followed them up afterwards. It was a mixed medical surgical ICU, so there were some surgical patients. Talking about sarcopenia, this is their muscle loss, basically, change in weight from the ICU. On the right, some life SF36, which is a quality of life outcomes. 5 years later, she published another follow-up paper looking at 6-minute walk test. They're still at 75% of the population. And she looked at quality of life, the top one being mental score, MCS, and the bottom one being physical scores, and the patients are still noticeably impaired compared to the general population. Remember, most of these were fit, healthy people before they got sick. And this paper started to change the way we thought about our ICU outcomes. We thought, survived to hospital discharge, perfect, absolute win, best outcome ever. Perhaps not. This is some work by Bagshaw. Again, the Canadians seem to be ahead of this, looking at 6 Canadian ICUs. This is done 2010 to 2011. It's a different population already. ICU populations, elective surgical populations have changed during this time. These people are aged 50 or more, and they use this incredibly complex Dalhousie frailty index. Basically, you know, you're very fit, you're well, you're managing, you're a bit vulnerable, you're mildly frail. And they picked 4 as their cut-off. And this was their clinical frailty distribution of the patients who came into the ICU. So it was a prospective study. They all had similar intensity of treatment on arrival in the ICU, but the frail patients were much more likely to have limitations, 34% versus 12%. And that's actually how people die. They die because it becomes clear that ongoing treatment isn't in their best interests. They rarely die on maximal therapy. And looking at the Kaplan-Meier curves of their outcomes, you can see that they continue to do badly. The frail patients, they continue to have a high rate of death. They have poor quality of life. They use more health resources. The other thing that's very important is they are much less likely to go home and live independently. They are much more likely to be living in institutional type care. And we know that that is one of the outcomes that's important to people. They're much more likely to be back in hospital with that or another problem. So far we've found that catastrophic loss of function is considered by some people an outcome worse than death. Severe critical illness does provide a major burden of disease and sometimes is a sequelae of elective surgery, even though we'd very much not like it to be. And whilst we can sort of predict population results, individual outcomes are a lot harder. We are getting better outcomes, and as the other speakers have shown, by preparing, we can reduce that risk as much as possible. So how do we talk to people about this? This is a study of inpatients in the US, looking at what they're actually looking at the demographics of how people feel things, but 97% prefer the doctors offer them choices, but 67% prefer the doctor makes the decisions about the medical care. So they want to be offered a range of options, but they want clear information and advice about what you're recommending, not what do you think, what do you think we should do. So our 80-year-old nursing home resident has a colon mass. Has he been told that 30% of these patients who undergo colectomy die within 3 months of surgery? They don't die straight away, they die within 3 months. Again, it's not the 30-day mortality. We can fix that, or the perioperative mortality. We're getting much better at that. It's can they recover from the surgery? 40% of those survivors have a significant decline in functional status. He's already in an institution. Is this an acceptable outcome for our patient? 12 months after the surgery, half of these people have died. Half the survivors have sustained a functional decline, and a quarter of the patients have probably returned to the function they were at beforehand. So how do you put this to people? Quill is one of the more erudite commentators in this area. He describes a concept called the time-limited trial. You meet with the care team, the patient, the patient's family. Sometimes it's the patient, sometimes it's the family. Sometimes the patient and family have different expectations. Sometimes the family want the patient to go on forever, and the patient's like, this hurts, I've had enough. Define the patient's problem. Make sure everyone's clear. That's the perioperative physician, the physiotherapist, the dietitian, the surgeon, the anaesthetist. You're all talking on the same page. You've all got a similar idea. Make sure that's communicated to the patient. Then find out what the patient wants, what outcomes are acceptable to them. Find some markers that might indicate where they're likely to end up in relation to those outcomes, and some timeframes to consider them in, and then define potential actions to take at the end of the trial. So if you operate on one of Obama's relatives and at 2 weeks they're in ICU with sepsis on a ventilator, you know it's going badly, and it's time to say, we concentrate on the patient's comfort. We don't push on. Now, it's important to understand that people's perception of what's important to them and what's important risk to them and what's valuable to them may vary. So, discussion with patients, it's really hard. It's not formally taught in medical schools, and as far as I know, it's not formally taught in many of the specialty programs, as far as I know. It is taught as part of the intensive care program, but really only in the context of organ donation, though the techniques transfer over very well. It takes a lot of time and a lot of patience. I think our first speaker said, the path of least resistance is to go ahead and do the procedure. That's certainly the case. If you do it more, it does get a little bit easier, but it doesn't ever get easy. And I think if it's got completely easy, you probably need to think about taking a holiday because you've lost perspective on what's going on with these people. Oh dear, the dog's here already. So I'm not going to read out the slides, but please, I use these with my trainees sometimes. Doctors don't understand statistics and relative risks very well. How on earth do we expect the elderly, terrified, sick person to understand relative risk? It's hard. So try to understand how they view possible outcomes. Try and have a consensus with your colleagues before you have that discussion, so you're all working off the same set of assumptions, and hopefully after that discussion with the patient they've got similar assumptions. If you embark on a course of treatment and it's not looking like it's going to end up where your patient wants to be, you should reevaluate it. And acting in good faith, acting according to the patient's wishes, is both morally, ethically and legally defensible, in my opinion. My wife said I was allowed to say legally defensible, which is good because she's a lawyer, that's my conflict. Getting back to Quill, he has an excellent article, Annals of Internal Medicine, talking about discuss the patient who wants everything. And he talked, do you want everything done? Of course I want everything you can do for me done. But it might mean that it might mean the patient wants to be alive to see a grandchild, to walk their daughter down their aisle at a wedding. There might be some life event that's very important to them. It might mean they don't want everything done but don't want to be a burden to their family. It might be that being hemiplegic and drooling is considered an acceptable outcome to them. If you don't ask, you won't know. This paper also goes through an excellent talk on harm reduction for continued requests for burdensome treatment, which Jenny has alluded to. Another good document, though it's very long, this is available online, is the ANZIC's document on decision making end of life. It's very ICU focused, but has a lot of principles and it's about 150 pages and a lot of vignettes and scenarios to take you through it. So there's an important role in prevention and early detection of problems. Not following simple measures is harmful. The exact techniques of how to do this really are a moving target. Severe critical illness, and including critical illness that's as a result of elective surgery, leaves a large burden of disease. There's a range of opinions in the community on what burden of disease is a desirable outcome. The best way to determine what outcomes are acceptable to your patient is to ask them. And these conversations are very difficult. Thank you.